Well, good morning, everybody. I am absolutely delighted to meet with everyone this morning and introduce my colleague, Dr. Christoph Griessenauer. Usually Dr. Glebus is here, and he's far more savvy at all these controls, but I am going to try to take over in his absence, and also at my request, because Dr. Griessenauer is not only a colleague, but he's a really, really good friend. And he's going to talk to us today about hybrid vascular neurosurgery in the age of technological development and increasing interdisciplinarity. And what I wanted to do is introduce Christoph to our GNI audience, but I didn't want to do it in a way that was just reading his CV. It seems almost like an obituary. And so I'll just go through this and relate to you, Christoph, as I know him. And first of all, he's a professor and chairman at the Department of Neurosurgery at Paracelsus Medical University. And without getting into much of the details there, I will say that he is the youngest chair, if I'm not mistaken. And so that in and of itself should speak volumes. For us here in the United States to understand where Dr. Griessenauer is in Salzburg, I think we have to understand the institution that he's at, Paracelsus. In order to understand that, and Christoph, I guarantee I'll stop babbling in a little bit. In order to understand that, you need to understand sort of the namesake. So Paracelsus comes from Celsus, who was an encyclopedist in the first century in Rome. And the only extant surviving piece of his work, of his encyclopedia, is his encyclopedia on medicine, or the parts on medicine. And from Celsus, we get, for many surgeons, you'll know the 4 signs of inflammation: tumor, dolor, calor, and rubor. And so that was Celsus, this encyclopedic person with information and knowledge. And then that brings us to Philippus Aurelius Theophrastus Bombatus von Hohenheim. He designated himself as Paracelsus, and that meant that Mr. von Hohenheim felt that he was at least equal to or greater than Celsus, meaning that he felt that his knowledge and his information was that robust. Paracelsus probably also changed his name at just the right time. The Turks were coming in through Austria, bringing coffee, and it probably made him telling the barista what his name was much easier. Paracelsus was a seeker of knowledge, and you can see here that he really visited places extensively, and we're talking about the 16th century. So for 7 years, he was traveling throughout Europe and going to Russia and even possibly Egypt. And I think that parallels Christoph's journey. For instance, Christoph is Austrian, but and he went to medical school at Paracelsus Medical School. Then he went to Yale, spent some time there. He was at the Mayo Clinic, where he did a research fellowship in neurosurgery. He was a resident at the University of Alabama in Birmingham. He did an open and endovascular fellowship in Boston with Chris Ogilvie, if I'm not mistaken. And then he joined us in at Geisinger Medical Center in Danville, PA. So before he headed back to Austria, he had his own journey and picked up his own knowledge, much like his namesake university. I think Christoph, I'd like to point out to you, without going through his CV, is an absolute researcher. Paracelsus felt the same way about research. As a matter of fact, he burned ancient medical texts like Avicenna and Galen's text in public, because he felt that he wanted medicine not to be practiced on precedent, but on relevance and science. And I think you can see, if you're curious, Christoph has hundreds of publications, and that's first and foremost in the way that he approaches medicine. Christoph is talking to us today about interdisciplinarity, and Paracelsus when he was at university, invited folks like barber surgeons, alchemists, and apothecaries, this sort of like probably unruly group of folks that must have looked like the bar scene in Star Wars at Mos Eisley. But I'm sure it was very unusual. And I think that that's what Christoph is going to show us, how interdisciplinarity makes us better and stronger. Finally, I found something that it's not going to really relate to Christoph, but it says, this is a quote from somebody talking about Paracelsus. For 2 years past in his company, was spent drinking and gluttony day and night, and he could not be found sober for an hour or two together. Well, Christoph certainly has, I don't think he's like that, but Christoph and I, we're on the ends here. There's a chef in the middle between us. We spent a lot of time eating and drinking and just enjoying each other's company, because when you're in Danville, PA, there's not a lot to do. I can say that my wine cellar is all the more poorer for Christoph's weekly visits, but I'm so happy to acknowledge my friend, to notice his accomplishments, and to introduce him to you. So really, without much further ado, I'd like to bring you Dr. Griessenauer and have him talk to us about vascular neurosurgery. Christoph, please take it away.
Well, thank you very much, Atom, for this very kind introduction. It's a pleasure of joining you this morning here from Austria. After many days of rain and a lot of snow, we finally got some sun today. I see. Okay, you can see my slides?
Yes, yeah.
Perfect. All right, well, Atom, thank you very much for your introduction. I also happened to learn a little bit more about the name giver of our university, so I appreciate that. I wanted to just briefly start by introducing myself. Atom has already said most of what was important, but I'm a native of Austria. I come from a small mountain town close to Salzburg, where I attended medical school, then spent time as a research fellow at the Mayo Clinic, followed by my neurosurgery residency at the University of Alabama, a fellowship in open and endovascular at Beth Israel Deaconess in Boston. And then I had the pleasure to go to rural Pennsylvania and come to Griessenauer, where I unexpectedly met an Instagram star, somebody who is, a professional, not only at neurosurgery, but also at, fine wining and dining. And I've really come very close to Atom and always enjoyed his company. And that's even greater that I have the pleasure to talk to his new, not so new anymore, but his current practice. So thank you for the invitation.
Sure.
And then close to 2 years ago, a little over a year and a half, I had the opportunity to go back to Austria to lead the neurosurgery department here. And I'll start with some of my clinical and research background, but I'll finish up sharing a little bit about the differences in the medical system between the US and then what I've encountered here in Austria. There were like three key moments that really, when I think back at my career so far, that were pivotal in most decisions. I would say one of the more impressive times was 2008. I was in my final year of medical school, and I had the pleasure to spend time as a clinical sub-intern at the Mayo Clinic. I was there for 2 months. Then I went to the Barrow Neurological Institute for a month and finished up just before graduating medical school at the University of Alabama. And I really appreciated the art of microneurosurgery, and I really became fascinated. And when we look at these illustrations from not so long ago, a little over 50 years, you can see that neurosurgery has tremendously changed. And even though we have, a lot of technological advances in terms of image guidance, in terms of neuromonitoring, new approaches, minimal invasive, endovascular, the art of neurosurgery and the appreciation for microsurgery has really also changed over the years significantly. Large tumors like these, which I do a lot more of now that I'm back here in Austria, where my practice in the US was mostly vascular. I have a more general practice now. we can take out very safely and we can preserve neurovascular structures, working under the microscope, working under the exoscope, and really using fine neurosurgical techniques, which is working with micro scissors, sharp dissections, and taking out big tumors, essentially without causing any long-lasting significant neurological damage. Post-operatively, the tumor is gone and the patient within a few months returns to have a relatively normal life. At the same time, even though we can treat a lot of vascular disease with endovascular techniques now, that has also made open surgery better. And, simple middle cerebral artery aneurysm, as you can see here, we are very gentle on the brain. We work without retractors, no forceful brain retraction, using sharp instruments. The sylvian fissure is open. All the small little perforators are preserved. And that's what makes the difference between a not so good and a great outcome. And I think, no matter how far we get in terms of the technological advances that we have all witnessed in the last years, and which has become even more prevalent with new computing and all the terms that we hear of AI and such. I mean, these are all nice adjuncts, but neurosurgery still requires the dedication. It requires the respect for the brain, and that's what in many ways guarantees, or at least assures, reasonable complication rates and good neurological outcomes. The second pivotal moment really was way before I entered medicine, 1995, when this idea of flow diversion for cerebral aneurysms was born. At the time, the idea was that you could deploy a stent in the vessel and give the vessel time to heal itself. Even then, they recognized that there is an issue with thrombogenicity, which we still face in today's practice. And then when I was a mid-level resident, 2011 was when flow diversion really became more prevalent. It's these densely braided stents that don't need any intra-aneurysmal component and lead to the healing of the vessel. We saw these pictures when I was as a resident, and I saw this in our practice, and it became pretty clear quickly that this is an absolute game changer in how we treat complex cerebral aneurysms. Nowadays, these procedures have become common standard. They're used all across the world, but they were really instrumental in my, making my career go the way it did. And the last pivotal moment, I would say, was 2015, when there was really broad evidence published that mechanical thrombectomy for large vessel occlusion was way better than best medical management. Everybody on this call has probably seen these pictures. I don't want to belabor it, but what I want to stress is that this has really been revolutionary for medicine. In 2015, 5 randomized controlled trials have been published in the New England Journal, all showing the benefit of this treatment. And we're looking at an intervention that's better than most intervention we can offer in medicine across any specialties. We have a couple of other good treatments in medicine too, like if we take out epidural hematomas or do surgery for epilepsy, number needed to treat are even equally low or even lower. But amongst the really prevalent diseases that we see in medicine, thrombectomy and stroke is certainly among them. What was a takeaway for me at the time was that if you wanted to do endovascular or vascular neurosurgery, you needed to appreciate the opportunities as a hybrid cerebrovascular neurosurgeon. For the US, that's very usual. People who want to do vascular essentially have to also be trained in endovascular, but in Europe, it's way different. I mean, here in Salzburg and in Vienna, we have a couple of centers where we have neurosurgeons that do endovascular, but there's a strict separation for the most part, especially in Germany and in France. Neuroradiologists do the endovascular and neurosurgeons do the open vascular, with all the obstacles and hiccups that we have experienced when these things are not in one hand. And what I want to relate is that we're not really simply offering a technique. We're treating a disease and taking this bias out that you can only offer one of two treatment modalities really gives you the opportunity to select the best treatment for your patient. How do you develop research interests? Well, as a surgeon, we are busy, and it's difficult to find time to, go to the lab. So the clinical and surgical practice and the research activities really have to overlap. And it comes down to patient-centered research that's driven by the problems that your patient has when you treat them clinically. And the question is, how do we make our treatments better? Well, in almost all instances, it's through individualization. We break diseases into further and further smaller parts. We see this in oncology, where we use mutation signatures to use targeted therapies to get the right kind of treatment. So individualization and taking apart what has traditionally been one and the same disease has helped us make us better. In terms of research success, what have been some prerequisites that have been important for me were some of the resources that I had, teachers, mentors. It also depends strongly on the environment that you're in. We used Griessenauer's MICO database to do some of our cerebrovascular genomic research. At Beth Israel, we had a significant database on flow diversion. And it's always a matter to find the resources at the facility where you're at, because there's few facilities that have it all. Collaboration, I think, especially in clinical and translational science, it's become harder and harder to publish single center series. So we have found a lot of success in teaming up with other sites, collecting more data, getting more robust data sets, and having more powerful publications. The interdisciplinarity I mentioned, it's not just the clinician, it's the interaction between the bioinformatics department, imaging, genetics, that really is what you need to create a more holistic research paper. And then last but not least is the persistence, just to not give up. I mean, one of my early mentors at Mayo just really told me that there is a home for every publication, and if you just keep trying and use the reviewers' comments, even if you're not asked to submit a revision, respond to them and use them to make the article better, and hopefully have more luck with the next journal. I want to exemplify my research interests along three topics: aneurysmal subarachnoid hemorrhage, flow diversion, and ischemic stroke. Aneurysmal subarachnoid hemorrhage, we know that outcome predictors, clinical and radiologic outcome predictors, are very important. But at the same time, these outcome measures that we use from clinical examination and from radiographics only explain about 31% of the variation in clinical outcome in subarachnoid hemorrhage. So there must be markers, so-called biomarkers, that are also important in determining how patients do after they have a ruptured aneurysm. In terms of the clinical factors that are important, we face this dilemma of the unruptured aneurysm. We know that unruptured aneurysms are incredibly common. 3 to 5% of all adults have unruptured aneurysms. We know that the rupture risk is relatively rare, in 1 in 2 to 300 rupture. And we know that ruptured aneurysm, if we apply so-called rupture prediction scores like the FACES score retrospectively, they all turn to have a low rupture risk scores. So a lot of the aneurysms that we see ruptured are small in size. They often have the characteristics that in and by itself wouldn't lead to the prediction that they would be likely to rupture. And I understand that the prediction score was not meant to assess ruptured aneurysm, but what we have shown in this paper here is that 60% of all ruptured aneurysms, if you retroactively apply the FACES score, would have a predicted rupture risk of less than 1% over 5 years, which is just a matter or a way to illustrate that this dilemma when we see unruptured aneurysms and the choice of whether we should treat them or observe them is a very complicated one. We also know that treating unruptured aneurysms for the most part hasn't decreased the incidence of subarachnoid hemorrhage. We treat more and more unruptured aneurysms, but the subarachnoid hemorrhage incidence is relatively stable. It's probably better if you want to prevent subarachnoid hemorrhage to stop smoking, get your blood pressure under control. From a societal aspect, that's probably the most helpful intervention in preventing aneurysm rupture. When we look at outcomes of ruptured and unruptured aneurysms, we can see that there was that real change with the publication of the ISAT trial. This is data from mostly from Mass General Hospital, where we looked at Chris Ogilvy's aneurysm practice. It was published in Stroke. And we can see that the outcomes for unruptured and unruptured aneurysms have significantly improved pre and post ISAT. So what is the reason for that? Well, one reason obviously was that after ISAT, endovascular treatments were much more prevalent, particularly in older patients. We see the synergy effect, which I was alluding to earlier. If you have a second treatment that you compete with to get good outcomes, also your traditional treatment has to get better. You know, clipping has certainly got much more safer and better because of good endovascular options that have just raised the bar for clipping to be safer. And we have made progress in terms of neurocritical care, in terms of subhydrocephalus management, prevention and treatment of cerebral vasospasm, delayed cerebral ischemia, and those things. And all these things together have resulted in better outcome in these patients over the years. One question that we never ask is, well, we always ask, well, is the aneurysm going to rupture or not? But we should also ask ourselves, if the aneurysm ruptures, what's the chance that the outcome is really bad? Because we also see subarachnoid hemorrhages that do very well from the get-go. And in this paper, which was a very neat idea from one of the Harvard medical students, we looked specifically at subarachnoid hemorrhages and looked at which factors predicted poor outcome. And we can again see that aneurysm size matters. So not only does increasing aneurysm size increase the likelihood of subarachnoid hemorrhage, but larger aneurysms also have a higher rate of having a poor outcome with subarachnoid hemorrhage. So again, it's the larger aneurysms that we have to be more worried about in general. And so this was more the clinical aspect of subarachnoid hemorrhage. Now we come to the biomarker or genomic aspect. First off, I wanted to kind of separate how you can look at this from two different angles. You can do a candidate gene approach where you look at very specific genetic regions and look at whether they influence outcome or not. Or you can do a genome-wide analysis where you need larger number of patients and where you look at what across a much wider range of genetic variants. And the first really genetic study that we have done in subarachnoid hemorrhage was the cerebral aneurysm renin-angiotensin study. We started that as a resident. It was funded by the Brain Aneurysm Foundation and also by the University of Alabama. Over 200 patients were enrolled. And the hypothesis was that variations in genetics in the renin-angiotensin system would have influence on, number one, the likelihood that aneurysms form and that the outcome in subarachnoid hemorrhage is influenced. And what we found was that local activity of the renin-angiotensin system, as well as systemic renin-angiotensin system, were not only implied in the development of cerebral aneurysms, but we also found that patients who had variations that were biologically proven to have a lower presence of this pathway also had worse, outcome in terms of Huntington-Hess score and functional outcome, or worse presentation of the Huntington-Hess score and worse functional outcome after the subarachnoid hemorrhage. Out of this study, we published a number of other papers looking at various biomarkers in subarachnoid hemorrhage. The one that seemed to be most promising was this high mobility group box protein 1, which is an acute phase protein. We set up a second study based on this and looked specifically at that gene. We looked at the expression of that gene and found that there was potentially some role for that gene in the development of delayed cerebral ischemia and cerebral vasospasm. With some of the data at Griessenauer, we teamed up with researchers at the University of Southampton in UK and the UK Biobank, and we recently conducted the first genome-wide association study on outcome after subarachnoid hemorrhage with centers from North America, Europe, Asia, and what was interesting is that we found one genome-wide significant hit, which is in the regulatory region of this sphingolipid transporter, the one that we know that makes biological sense that when this variant is present, the expression of that transporter goes up, and the sphingolipid 1 phosphate increases, which has been proven in stroke to activate microglia, enhance neuronal death, inflammation, and blood-brain barrier breakdown. Here, this mutation is shown in a little bit more detail. It's in a regulatory region at this zinc finger binding location. And what was interesting is that this has also been targeted in other diseases. Fingolimod is a medication that's licensed in multiple sclerosis, and there is some idea that this agent could be neuroprotective in ischemic or hemorrhagic stroke. This is some very early data. Now the question is how we can validate that externally. The problem with a lot of GWAS studies is that they are difficult to validate externally, so we're in the process of enrolling more sites, getting other centers to participate, patients, and maybe find a relevant target. The second part is on flow diversion of cerebral aneurysms. I've already mentioned that flow diverters differ from traditional stents, whether they're used in cardiology or in stent-assisted coiling significantly. They are very densely braided. They have a low porosity, which means that the area that is metal-free is much lower. They have many more pores, so the pore density is significantly higher. And the challenge in the brain is that when you use the cover stent, so if the stent is completely covered, side branches get occluded. So we want to occlude the aneurysm, we want to conform to tortuous vascular anatomy, and we want to keep the side branches open. And that's what flow diversion enables us to do. Here you can see the idea that the flow diverter is placed across the aneurysm, across the side branch. It decreases the kinetic energy within the aneurysm that leads to aneurysm or blood stasis and eventually aneurysm thrombosis. This is illustrated here. And really over time, the vessel heals itself, the aneurysm reabsorbs, disappears, and the vessel really looks normal, just as I've shown on the earlier images. And we have built this flow diversion consortium really from sites from North and South America, Europe, Asia, and collected data, looked at various clinical aspects of flow diversions, have published over 40 manuscripts on this. And here I want to just go for some, special considerations from some of those publications. We've already said that those flow diverters are very high in metal content. So they have a very high propensity to form thrombi. The thromboembolic complication rate is significant. We try to find answers to that by starting patients on dual antiplatelet therapy. And what has really also puzzled us, whether we should test the response to those antiplatelet agents with platelet aggregation tests. And the three agents that are really used broadly are always a combination of aspirin plus clopidogrel, ticagrelor, and prasugrel. Clopidogrel and prasugrel work on this P2Y12 receptor. They are prodrugs that are given as a prodrug and then metabolized in the liver. A newer agent is ticagrelor that not only works on the P2Y12 receptor, but also has another mechanism with this ENT1 channel that increases adenosine, and thus this adenosine increase also results in platelet inactivation. This works through the cyclic AMP pathway, which leads to phosphorylation of vasodilator stimulated phosphoprotein and eventually platelet inhibition. And we can also measure this response in various tests. Gold standard, we say, is light transmission aggregometry, but what is very in vogue, I would say, is using a bedside test. One of them is Verify Now, and you can measure these P2Y12 reactive units on patients on clopidogrel, but also on the other agents. For clopidogrel, the goal range is somewhere between 60 and 200. Below 60, you will tend to be a hyper responder, so the blood is too thin and they tend to bleed easily. Over 200, there's the other response. They don't get enough inhibition and they tend to form clots. The issue with clopidogrel is, like I said, is that the number of patients that are resistant is up to 40%. There's a number of reasons: non-compliance, wrong dosing, medication interactions. We know it interacts with proton pump inhibitors, but also some statins, nimodipine. There's genetic variations that are very important, like people may just not be able to metabolize clopidogrel through the CYP2, C19 pathway, for example. Alternative platelet activation pathways play a role. And this study was published in Stroke, and I think there is one unique aspect to the study, and it's since confirmed by a randomized controlled trial from China. But what was unique in the study is that we included 3 centers, and it's certainly scientifically not the most clean study, and maybe the results are a little bit exaggerated, but I still think there is some deep truth to what this study showed. At one site, the institution did light transmission aggregometry, and they switched all their non-responders to ticagrelor. That was institution A. At institution B, they did a different type of blood test, which is called whole blood aggregometry. And I want to say that none of these are really like, there's not this one gold standard, and people have pursued different ways. But what was unique at this site was that it was in the early days of flow diversion. And people didn't really know and believe whether switching patients, if they were non-responders, really had any impact. So the practitioners there said, okay, well, the companies want us to do this, but we really don't believe in it, so we do it, but we don't really switch our patients, or we don't switch the patients, which gave us this unique set of data where patients that were proven non-responders, at least according to the test, were not switched. Because as soon as you switch a patient, you introduce a new bias into your analysis, and it's hard to then analyze those data. And at the third site, they gave additional clopidogrel for their non-responders. And when we look at the thromboembolic complication rate, we could see that the clopidogrel responders had a reasonable complication rate around 5%. The complication rates with flow diversion today are lower than 5%, but still probably, and if you look at honest data, somewhere between 3 and 5%. Those that were switched to ticagrelor had even lower complication rates. Those that got a boost of clopidogrel had a higher complication rate than the responders, but it was still somewhat reasonable, especially in the earlier days of flow diversion. But what's really staggering was that patients who were proven non-responders and who were not switched and kept on clopidogrel had significantly higher complication rates. I would tell you to take this number with a grain of salt, because the truth is maybe lower, but there's, in my opinion, I'm convinced that there's some truth to doing platelet function testing. And to me, to switch a proven non-responder, no matter which test you do, is just not state-of-the-art practice. But there's still institutions that really don't believe in it today and still don't test for antiplatelet response. And as I alluded to earlier, there was a recent study published from China, and I think also in Stroke, that showed a benefit of platelet function derived tailored management of antiplatelet agents. We also looked at ticagrelor because we had some patients on ticagrelor who had complications. And I don't want to go into the details to that, but the cutoff values for ticagrelor may be different. But I would also urge people on ticagrelor to be tested at least once, because in even very rare instances, there may be people who don't respond well to ticagrelor either. And at Griessenauer, this goes back to interdisciplinarity. We teamed up with the clinical pharmacy department. We had this very elaborate protocol where pharmacists at Griessenauer would follow these patients very closely. The protocol is shown here. It's quite detailed, but essentially for 6 months, for a couple of weeks before the flow diversion procedure and 6 months after, and then we expanded this to all intracranial and extracranial stents, we had the patient meet with the pharmacist really continuously, make sure that they were compliant. We checked their platelet function test repeatedly every few months to make sure that they were still responding. And really that, in my opinion, was a critical step to minimize complications. I mean, it's laborious, but the pharmacy team was motivated. And I think the patients did see a benefit to doing that as well. The larger clinical research topic I want to touch on is ischemic stroke. With Errol, you have a leader in the ischemic stroke world at your facility. He was on the forefront of this development. I actually stole this from one of his talks where he said that, ischemic stroke is becoming much more of a surgical disease. We have seen this with the management of traumatic neurovascular injuries, where we have done some research on mostly at UAB. Thrombectomy for large and medium vessel occlusion strokes, I've already mentioned, it's become state of the art. It, has resulted in systems of stroke care to change, all across the globe. We see stroke care of endovascular strokes in terms of endarterectomy, stenting, TCAR bypass. So stroke in all facets has become a surgical disease. In terms of the traumatic injury to carotid and vertebral arteries, the CAVIS study was one of the studies that we did when I was a resident. It was led by one of my mentors, Mark Harrigan. And what was interesting is that we had a high number of patients who had TCBI, traumatic carotid vertebral injuries, but the ones that had strokes tended to present very early. And we found that patients who came in to the hospital intact without a stroke had fairly benign course that an aspirin was usually enough. We also found that if spine fractures were associated with complete vertebral artery occlusions, our intuition was that maybe surgery wasn't safe at that time. We could dislodge a clot. Our analysis showed the exact opposite. Those were stabilized early, had a lower stroke rate than those that were maybe just immobilized in the collar. We also used optical coherence tomography at the time to look at traumatic aneurysms of the cervical carotid arteries. Those are frequently labeled as pseudoaneurysms. They're not really pseudoaneurysms because usually it's just a tear in the intima with a stretch of the median adventitia, whereas a pseudoaneurysm really is a complete tear of the vessel wall with just an adventitial cap. So really, it's better to refer to those aneurysms as traumatic aneurysms, not so much pseudoaneurysms. And that work has led to a multi-center study that Dr. Harrigan is leading in the US that is hopefully taken off very soon, where there is a prospective study that looks at carotid and vertebral artery injuries in trauma to find the optimal way of managing those patients. Mechanical thrombectomy, we already talked about a little bit. 2015 was the first game changer year. I think the second game changer year was 2017. Then there have been many more game changer years. In 2023, we showed that there's a benefit in low aspects strokes. We could finally prove that there's a benefit in basilar occlusions with mechanical thrombectomy. But what really challenged us at Griessenauer was the 2017 rolled around. The Diffuse 3 and Dawn studies showed that even up to 24 hours, there's a benefit to doing thrombectomy, but we didn't have really broadly available perfusion imaging at the time. And we just made the conscious decision that we wouldn't want to wait for administration to get that realized. We would basically just, work in the favor of the patient, use what we had at our disposal, and also thrombectomy patients out of the traditional window. And this has been shown now by many other investigators as well, is that you don't necessarily need to use advanced perfusion imaging. I mean, the studies recommend it, but if you just go by CT aspects, even up to 24 hours, you can still get decent outcomes. The outcomes decline over time. I mean, that would, we would expect that. But at the same time, those that were in the later window were not statistically significant in terms of outcome compared to those in the earlier window. And this is a problem that, that arises when we over-select patients. Earlier in my talk, I talked about individualization. And for most medical treatments, that's true. But sometimes when you look too closely, especially when you have a very safe treatment, just as thrombectomy, you tend to exclude patients that may have benefited from the treatment. When we look at this little scenario of 20 patients in a large window, let's say we use CTA, C2 perfusion, and based off a presumably large core, we exclude already 30% from the treatment. We exclude more patients, but the efficacy goes up because we only include the better patients. If we look at our 20 patients, we have excluded 6 from the get-go based on the C2 perfusion. They never even made it to the angio suite. Of the remainder, 50% did well. Great. So those, remaining patients, we've really helped significantly. On the other hand, we don't use perfusion, so we cannot exclude anybody a priori. So we give them all the benefit of the doubt. We assume that their core is large enough, small enough that they would still benefit from the intervention. Our efficacy drops because our selection criteria drop, but at the same time, with using all patients in general, we benefited more. So in the first scenario, 7 patients benefit, in the other benefit, even with lower efficacy from thrombectomy, 8 patients benefit. And this is where we're heading. We're heading in a way that we thrombectomize more and more patients because we all want to give them the benefit of the doubt in terms of believing that their core is still small enough that we can help them somewhat with our intervention. So when the treatment is very safe and very efficacious, over-selection can be problematic. This now kind of bridges the gap a little bit outside of the clinical setting. This is also work we've done at Geising in collaboration with Yale, where we have used radiomics. Radiomics is a technique that I can only describe as an amateur, basically, because I'm also not a computer scientist. But basically, what radiomics do is they filter out this information that is in the pixels of the CT or a CTA that is not really visible to the naked or radiologist's eye. And what we can show is that radiomics on the very early imaging can be very good at predicting outcome in patients that undergo large vessel occlusion thrombectomy. We also did work with MGH in the so-called MRI GNI studies. These were some papers that were published in Nature and Brain, where we collaborated and used the data from our MyCode data set, where we could see that there is distinctly different lesion patterns and stroke severity and outcome between women and men. Like in women, the non-dominant parietal lobe, when that gets injured, seems to have a much greater effect than in men in terms of their likelihood to have a severe stroke or stroke outcome. So we learn more about variations in stroke location and how they influence outcome between different patient groups, just as between men and women. When I wanted to take you back to genomics and cerebrovascular medicine, we generally have the problem that most cerebrovascular disease is not monogenic. Monogenic is the classic cerebrovascular disease. For example, factor V Leiden mutation. You have a mutation that results in a certain change in the biology of that patient, and that puts the patient higher risk for a significant clinical event. In cerebrovascular disease, most of those diseases are multifactorial, the way we eat, our habits, our exercise habits, and probably also our genes predetermine how we're doing. And it's probably a lot of genes that contribute, but each gene has a relatively small contribution. So one way of answering this question is through so-called polygenic risk scores, where you take clinical data, imaging data, genetic data. This can start with a GWAS, like I illustrated earlier on subarachnoid hemorrhage. You identify some potential genes of interest. Then it goes to trying to validate those findings. That's where it often becomes complicated because often GWAS findings are difficult to replicate. And then you add additional factors. You add clinical factors, you add imaging factors to take those stroke patients and break them down into smaller and smaller cohorts. And the idea is that eventually you find a target that in a very specific group of patients can be used for example, drug development. Here I want to illustrate the example of polygenic risk scores one more time briefly. On one hand, you have a low risk patient, maybe with just a few risk alleles. On the other hand, you have another patient with a high number of risk alleles. And it's not just the alleles, it's also the clinical data, as I mentioned, laboratory values, imaging, and so forth that should be used in these polygenic risk scores. And here's some data that we did with one of the stroke neurologists at Griessenauer, which was an interesting study where we were able to basically just with those imaging and genetic data, not imaging data, genetic data, we were able to basically categorize those patients according to their toast type. So somewhere deep in our genes, the information of which stroke subtype we have is already located, and with modern computational analysis, then that can be extrapolated and made visible. We can also use polygenic risk scores to predict survival of strokes. So these are some of the examples of research we have done on this domain. I think the future for neurovascular neurointervention is bright. With the embolization of chronic subdural hematomas, we have a treatment that we have also introduced here in Salzburg when I joined here. This is a topic that's being studied extensively, mostly in the US, but also in Europe in clinical trials. And maybe in a few years, there's going to be more hopeful, positive evidence that this treatment is beneficial than for any other disease that we treat in neurosurgery. There is research on endovascularly introduced CSF to venous shunts. And the vascular system is also a way to interact with our brain from an electrical point of view. There is some important work done with this device called a stentrode, where a stent with electrodes is placed in the suprasagittal sinus next to the primary motor and sensory area, and those signals can be extrapolated to use in brain-machine interface technology. I want to stop the research part here and talk a little bit about neurosurgery here in Austria, because I felt it may be interesting for you in the US, because there's quite some differences. And when I came as somebody who has studied in Austria but never actually clinically practiced here, you know, I had some sort of rough awakenings at times when I had to get accustomed to the local habits here. Our department is 55 beds. We serve the state and city of Salzburg. Salzburg is about 170,000 people. The state of Salzburg has 600,000 people, but we also serve surrounding states, even surrounding Germany. Bavaria is not too far, so we get patients from Bavaria, from Upper Austria, from Styria, from Tyrol. So we have 55 beds. We have our own neurointensive care unit that has 12 beds. We have bed specifically for spine patients, private supplemental insurance patients, and public insurance. We have 24 neurosurgeons, over 100 nurses, but we have an extreme nursing shortage that results in almost daily OR closures. We're supposed to have 3 operating rooms and the angiography suite. As I said, that Salzburg and Vienna are one of the few sites where there's true hybrid cerebrovascular neurosurgery like we're used to in the US. And we do about 2,000 surgeries per year. In terms of the differences between the US and Austria, one big difference is that 99% of people in Austria are insured. There's more like a Medicare for all type of insurance that is funded out of income taxes, various taxes, and insurance contributions. Hospital funding is through the state. So Austria has 9 states. And the amount that is basically dedicated to hospital care is fixed every year. So even though we have a DRG-like system, when we do more procedures, we create more DRG points, but the point value of the DR essentially decreases because the amount that is dedicated to medicine basically is fixed every year. Nevertheless, the healthcare expenditures have gone up even in Austria at a rate that's higher than inflation, but certainly not as great of a rate as in the United States. The private sector is growing because, like I said, with OR closures, there are significant wait times, and there's a number of private practice neurosurgeons here in Salzburg that do very well. They only take self-pay. They operate at smaller hospitals, private hospitals, and they make good money doing that. And they don't do anything complex. There's no cranial surgery outside of the academic institutions. So all cranial surgery in Salzburg is doing at our facility. We also don't have another academic center that we compete with. But for private, supplemental private insurance patients, we certainly have some competition because they get earlier appointments. Even we are at the public hospital, we're not allowed to treat people with private supplemental insurance preferentially, so we cannot give them earlier appointments. The wait time for spinal fusion in our institution at the moment is about 6 months. And we have a growing personnel shortage because the OR nurses and nurses in general at the private hospitals are paid better. Physicians are paid better. They work a lot fewer hours for the same salary than they do here, and it's a real problem for us to recruit. Even though neurosurgery is better than other specialties, because for those that want to do cranial surgery, they can't go out in private practice. So maybe a greater incentive to stay in the academic environment. From a physician perspective, we have duty hour limits. Everybody except for the chair has a duty hour limit. So it's technically it's supposed to be 48 hours, but at the moment we cannot make that. So there's a so-called opt-out rule of 55 hours per week. But the European Union wants us to go down to 48 hours. I'm not sure how we're going to do this with the amount of workload that we have. Everybody gets six weeks of paid vacation. If you work here for a certain number of years, you get 7-8 weeks. If you're exposed to radiation, you get an extra week. So I have people in my department attendings who get 9 weeks of paid vacation, which you can imagine is very challenging at times. What is also interesting is that the pay for physicians in the hospital is the exact same for everybody, except for the private insurance supplement. So the pediatrician and the neurosurgeon get the exact same gross salary, which for an attending here is including their call pay and private insurance pays about 150,000 euros. So those are in the top tax bracket. So you have to take away about 50% to know what your base pay is. And for my colleagues in the United States that do neurosurgery, they know that that's a lot less than what is paid in the United States. All of our attendings take in-house call because in-house call is a major component of their pay. There's no such thing as a productivity reporting per physician. Like we look at productivity across the department, but we don't track productivity in any way per physician. So that component doesn't exist. We have a centralized OR scheduling, so we don't really have personalized care in the sense that it's up to the chairman and the vice chair to schedule the OR for the next day. And I'm the one who decides which attending gets to operate which case. So there's not a very strong patient-physician bond, except for some very specific things like for DBS, we only have one person who does DBS. For the transnasal stuff, we have really only one person. For some of the ECG electrodes and epilepsy surgery. So for those very specific topics, we have specific people, but for everything else, spine, tumor, vascular, we have groups of people that take care of that patient pool. And as a chairman, you're expected to operate all the private supplemental insurance patient, which requires me to also do some discectomies here and there. And I do a lot of more brain tumors these days, just because that's the private insurance pool that we take care of. In terms of what we plan for the future, I can assure you that the care here is great. We have very modern equipment. I had much better equipment now here at Salzburg than I ever had in the United States. We have brand new Kinevo microscopes, state-of-the-art imaging technology. So the state does invest quite a bit in the hospital in neurosurgery. We are in the plans of building a hybrid operating room with MRI and angiographic imaging technologies. We're supposed to have a new regional trauma center here for the state of Salzburg and get new premises for conferences, research, and teaching. This is the university, and you can see that neurosurgery here in terms of research productivity is among the top institutes. We are the most productive institute among all surgical specialties, and in the recent years our input in terms of publications has gone up significantly. I could do this not by myself. This is my team. So we have, like I said, 24 physicians. We have nursing leadership, and these are the people that I owe everything to, that we provide to our patients here in Salzburg. And with this, I want to give you some impression of Salzburg. The quality of life here is amazing. That's also the reason why people don't want to work so much, because we have beautiful lakes, we have beautiful mountains. People post-call go up on the ski slopes and go skiing on their post-call day. In the summers, they are at the Salzburg Music Festival. and enjoy life here, maybe a little bit more than what we're used to in the United States. Under these circumstances, I can only invite anybody to come visit. You'll definitely regret it. There's a lot to explore, and with this, I'm going to close, and I want to thank you again for your time and attention.
Hey, Christoph, thank you so much. That was really wonderful. I was going to ask what you miss about practicing in the US, but I guess the answer to that is nothing. And we've sort of come really close to the end of the hour, but I did want to ask you something because you pointed out how you had that really interesting Venn diagram that you made the right point. I've seen neurosurgeons that try to do research outside their field of interest, and it's really tough because we're always in the OR. People that really exemplified that at being able to do that were people like George Ojeman, who would do all his epilepsy recordings and then turn that into R01 funding. Now that you're doing less vascular, what approach are you taking towards your tumor patients, and what interesting research projects are you doing there, or do you have anything that you're formulating yet?
Just to answer your question, maybe in a slightly different way, in the vascular world, it's made us very easy because there's been a lot of device development that have really gone parallel between the clinical practice and also the research practice. Here in Salzburg, we have Monika Killer. She's my neurology counterpart, who is a very prolific animal laboratory. She actually does a lot of the device testing, even for US companies. So we have a lot of US investigators come to Salzburg to test their devices in rabbit models. So endovascular lends itself to bridge the gap between clinical and research practice easily. In oncology, it's obviously a little bit more difficult. One of the things that we do is we do a lot of methylome profiling here, for example. That's something we collaborate with our oncologists in our pathology department. We methylome profile all CNS tumor patients here. And that's what some of my attendings are working on, and some of the residents to kind of bridge that gap using that Heidelberg classifier to reclassify brain tumors. But you're right. I mean, as a neurosurgery resident and even as an attending, it's very hard to find dedicated research time. And here there's even less funding for dedicated research time. Just simply doesn't exist. You either do it in your spare time or you don't. And there's less incentive here to do it also. So for those that do it in their spare time, and I try to support them as much as I can with non-monetary measures, but these things have their limitations, obviously. And with the shortage of staff, the clinical obligations become bigger and bigger.
Absolutely. Well, Christoph, I think your practice is enviable. I absolutely am just delighted to see your success, and I'm just really equally delighted to call you a friend. And I can't wait to visit at some point in time in Salzburg, and hopefully at some point in time we'll even have you here in person. I'll end at closing and thanking you for your time and reminding everyone that in another 2 weeks we'll have another grand rounds, and their EADS code is 12JAM for those of you that are taking CME credit. Christoph, thanks so much. Have a good afternoon and have a wonderful weekend.
Thank you very much.